tonight, I want to take a different tack, and we're going to be talking about free market healthcare solutions. We've got some very real opportunities on how to actually lower the overall cost of care while improving the quality of care. I know that seems like they don't go together very well, but throughout tonight, you're going to hear some success stories that talk about how we actually can do this. And the reason we're in this evangelism mode is that we want to get the word out to everybody, especially in context of all the policy discussions that are happening at the state level and at the federal level. But in order to frame tonight's discussion, there's kind of a key concept that I want to get across. When we talk about a health plan, we're dividing it up into two basic Lego blocks. We're going to talk about it from a perspective of primary care, and then we're going to talk about it in terms of catastrophic care. What we're proposing tonight, one of the centerpieces of and one of the keys to lowering the overall cost of healthcare is going to be drilling down on how to make primary care more effective, more efficient, and more focused on preventive care. Because if you do preventive care right, you minimize the costs on the catastrophic side, and that's where the big dollars come in. That's where the long hospital stays come in. That's where the chronic conditions come in. If you do the preventive care right, that circle gets a heck of a lot smaller, and that's what we're going to talk about tonight. Does that make sense?
It does.
All right, so to frame this discussion, I kind of want to go back to an old Milton Friedman model, if that's all right. It was actually introduced to me by Congressman Bob McEwen out in Ohio, but I think it's appropriate for our discussions tonight. There's three basic types of economic transaction. You've got first-person transaction, where you're cost-conscious and you're quality-conscious because you're buying it for yourself with your own money. So you're going to be worried about cost, you're going to be worried about quality. Second-person transaction, I'm going to be worried, I'm buying something for somebody else. I'm concerned about cost, but quality, you know, there's a reason why they have regifting, right? So it's a little bit different. Now when you get into third party, now you're using somebody else's money to pay for somebody else's product or service. Your cost consciousness is low and your quality consciousness is relatively low. You know what the problem with that third party transaction is? All government transactions are third party transactions. So the more we get away from the first party transactions, the more we're going to get into a model of service delivery that is not cost conscious and it's not quality conscious, which is kind of where we are today, right? Especially when it comes to healthcare. So I'm going to talk about a couple different primary care options. Essentially, you have insurance-based primary care options where you've got independent insurance-based practice, you've got a managed care organization, you've got a hospital-based care practice. My wife's been through all these different practice models as a pediatrician. What we're going to talk about today, and a lot of emphasis, is some of the key first-party transactions that don't involve a third party like you see on the left, and they're direct primary care services. And we're not going to talk about this too much because it kind of makes sense. It's just a cash model. So you're going off the grid and you're just going off and saying, give me the cash price for that service. You don't have any benefit of any agreement or anything else like that. You're just going to a physician saying, hey, how much would it cost for you to put a cast on me, or whatever the case may be. We're not going to focus on that. We're going to talk about this direct primary care service model tonight. Now when you get into the catastrophic care options, you have something called a qualified health plan. Thank you, ACA. That's where that term was introduced. Qualified health plan is essentially the list of acceptable plans that will keep you from receiving a visit from the IRS in the middle of the night saying you haven't paid enough for your health care and you haven't gotten the right type of health care insurance. There's one exception or exemption under qualified health plan, and that deals with ERISA-based self-funded insurance plans. And I think Teresa's going to touch a little bit about that tonight. But there's a couple other areas that Joe Schmidt's going to talk about, is something called a healthcare sharing ministry with Carol. So this is going to be where that fits into the overall piece of the ACA. And once again, these are exemptions under the Affordable Care Act right now. And then just like with cashier's primary care, you can go to the open market on it. And there are some radical new practice models like Surgery Center Oklahoma, where you can get catastrophic care for 10 cents on the dollar, what you would cost in a traditional third-party insurance practice. And it's high-quality stuff. People are coming all over the world to go to take advantage of this practice. So so we talked about the primary care options and the ones that are first-party transactions. We talked about the catastrophic care. So why does this matter? Well, we all personally know why it matters, right? We're all struggling with rising premiums and rising deductibles. I was just talking to somebody earlier where their deductibles were on the order of $15,000. I mean, what good is health insurance if you're paying $15,000 out of pocket before you receive any benefit? So DPCS in particular, I'm going to focus in on that, has been proven to lower costs while improving the overall quality of care. And what it means here in the state of Michigan, let's start with the Medicaid budget. Right now we spend $18.6 billion on Medicaid in the state of Michigan. That is by far the single largest line item in the state budget. So if you can find a way to go off and deliver that for 20% less while actually improving the quality of service received by Medicaid enrollees, don't you think that's something we should kind of look into? And so you can save potentially $3.7 billion per year on our budget for taxpayers, and about $1.5 billion of that is state dollars. So if you're wondering why I was so adamant against the increase on taxes for roads, well, we got potential savings here on the order of more money than they're looking at putting towards the roads, while actually improving the quality of services that we've received. So there's plenty of money out there, and I've got a pilot right now. It's me going through the budget process this time. And if you have any friends up in Lansing that can lend some encouragement and encouraging nods to folks in key places up there, we'd really like to get this across the finish line this year. And it's a DPCS Medicaid pilot. There's 2.4 million Medicaid enrollees in the state of Michigan. We're just proving our point with 2,400 enrollees, and we just want to start off with that. And once we demonstrate the savings that we're talking about here for that small panel size of 2,400, then we can start expanding this model out to 2.4 million enrollees. And it's not going to happen overnight, but we want to make the case for why this is something we should be doing here in the state. All right, we can also be using this for public employers. In the state of New Jersey, this is not a Republican policy, by the way. New Jersey, Democrat-controlled legislature, is promoting something called R-Health for all the state employees, and it's got direct primary care as the cornerstone for their policy, and they're saving millions of dollars with these policies. So if we applied that here in the state of Michigan, we could potentially save about $280 million per year in our state budget. That's kind of a big deal. So look at private employers. This is where it gets really exciting. If we expand the footprint of direct primary care service providers here in the state of Michigan, we've got 10 million citizens. We spend over $35 billion a year in the private sector on health care. If you can go off and free up 20% off of that, now we're talking $7 billion a year that you could put towards higher wages, hiring more employees, becoming more cost competitive. Michigan would be the center of a free market healthcare revolution, and also the center of a job growth that we have not seen in a long time, because we'll be 20% lower than anybody else around us.